if they do, they're so cool.
Yeah.
Okay.
Hello, everyone. Thanks for joining. I see folks coming in now. Thank you all for being with us. We're just going to give it another minute while we let folks move over from the last session. Hopefully everyone had a great opening session with a fantastic conversation. So glad to see such great work coming out of the White House conference. I see a couple more folks joining. We'll be starting in just a moment.
Cool. My daughter has an 11 a.m. dismissal today.
All right. Well, thank you everyone who's joining us. We have a couple of announcements as we see everyone get logged in. First, I just wanted to make sure everyone knew this session is being recorded. It will be available here in Excel Events and on the Alliance website within the next 2 weeks. Next, you'll notice that this session allows you to have your cameras and mics on. We ask that you follow the presenter's lead for when to do so. And lastly, if you'd like to ask any questions during this session, please make sure and use the Q&A area to the right of the viewing window. It looks like we're ready to begin. So Brittany, I'm going to throw it over to you.
Thank you so much, Sam. Good morning or afternoon, everybody, depending on where you're coming from. Our team today is going to be presenting on how we're using primary care settings to address food insecurity. Next slide, please, Kate. So first, before we get really into the weeds of things, let's introduce who is going to be presenting to you today. My name is Brittany Goldstein, and I'm a program coordinator at Denver Health, and I play a role in managing the Specialized Co-Enrollment Program that we're going to be discussing with you all today. I'm joined by two incredible colleagues who will be co-presenting with myself. Kate Corneland, who's our manager of the Denver WIC program, and Meg Tomko, who's a physician and leader in our pediatrics department at Denver Health. So for us to better understand who we're talking to today, if you don't mind just putting in the chat where you're coming from geographically and maybe why you are interested in our session today. And with that, I will go ahead and kick it off to Meg Tomko.
Oops, Meg, you are on
I'm
mute.
sorry. Before I give it to Meg, I'm also going to just share with you guys the flow of today. So sorry about that. We obviously are introducing ourselves and where our work is happening here at Denver Health and in collaboration with Denver WIC. We're going to discuss a little bit about food insecurity and what we're seeing both from the Denver WIC side and also when we are serving our patients at Denver Health. We'll talk about our intervention, which we call Specialized Co-Enrollment, and the outcomes of that program. We'll also share a few things about the lessons that we've learned thus far of implementing this model and what the future of our co-enrollment program will look like. And then we'll leave questions to the end. And as Sam mentioned, if you don't mind putting your questions in the Q&A section, that would be great. And that way we can address all of your questions at the end. Thank you.
All right. So we are coming from Denver Health, and we're an integrated health system that serves as the safety net for the city and county of Denver. We are a large 555-bed hospital. We're the leading trauma center for the region and 911 response system. We have multiple outpatient medical centers and federally qualified health centers that serve as the specialty and primary care clinics for over a third of the Denver population. We have urgent care locations, including virtual urgent care, school-based health centers, mobile health vans, and behavioral health units. So we are a large integrated system. Our community health service clinics are located in the most under-resourced, highest need neighborhoods in the city, and we have over 180,000 unique patients. Similar to other federally qualified health centers, more than half of our patients live below 100% of the federal poverty level. And we have a very diverse patient population with over 70% identifying as an ethnic minority and about a third non-English and a third non-English, non-Spanish speaking patients.
All right, and this graphic shows where our WIC offices are located within the Denver Health Hospital system. And our WIC program serves about 12,000 participants monthly and is located in 6 of Denver Health's 9 neighborhood clinics. And for those who haven't learned a lot about the WIC program in the past, WIC is a special supplemental nutrition program for women, infants, and children. And the aim of the program is to improve the nutrition and health of pregnant and postpartum women, infants, and children up to age 5. And this is done through prescriptive food packages, nutrition education, breastfeeding support, and community referrals. All right, so this graphic shows the percent of participants who are eligible and also enrolled on the WIC program. And this data was gathered prior to the COVID-19 pandemic. And on the y-axis, you can see the total percent of the eligible and enrolled participants. And on the x-axis, you can see the counties in Colorado. The line through the middle is at 60% and shows the goal for eligible and enrolled. And Denver, where our Denver Health Hospital system is located, is sitting at about 46% eligible and enrolled. And the Supplemental Nutrition Assistance Program, also known as SNAP, fares a little better. They have about 60% eligible and enrolled. Their goal nationally, however, is 73%. And Denver Health conducted a social needs assessment in a pediatrician office and the emergency department, and 16,000 patients were screened, and 34% identified at least one health-related social need, and the highest portion was for food insecurity at about 21%. And this really shows that there's a high prevalence of food insecurity, a gap between those who are eligible for food support services and those who are enrolled, and a healthcare system that lacks standardized protocols for referring food insecure patients and families to federal or community-based programs that provide food. Some of the potential barriers to enrolling and maintaining enrollment in the food assistance programs are confusing eligibility requirements, lack of information about the programs, possible concern about public charge, and challenges with frequent appointments.
We are all here likely because we understand that food insecurity is associated with lots of different poor outcomes among children. But I think it's always good to remind ourselves that these can be very devastating in terms of health outcomes, but also developmental issues, mental health issues, and educational outcomes. Food insecurity can present a number of different ways in the clinical setting. This slide shows the increased odds of poor health outcomes compared to those without food insecurity. Again, not anything that's a surprise to everyone here likely, but always worth mentioning just because of the impact that food insecurity can have on children and families. Now, there are many solutions to address food insecurity, and we absolutely support short-term solutions such as food banks, grocery gift cards. We feel that participation in federal assistance programs are longer-term solutions to the social need of food insecurity. Ultimately, we know that the systemic issues such as institutional racism, geopolitical conflict, poverty, social determinants of health, and health inequities are at play. We continue to advocate for those to address the systemic issues. We're also working to promote the longest term solutions possible. And we know that participation in federal assistance programs is one very effective tool to address food insecurity. So where did we start? We took some first steps in our ambulatory care clinics that serve children and families, so pediatrics and family medicine. And to encourage the WIC participation, we began with some steps during the rooming process. So our medical assistants, while bringing children back for a well child visit, would ask families about WIC enrollment, WIC participation. If the parent or caregiver said that they were enrolled, the medical assistant would give positive reinforcement. If the parent or caregiver did not say that said that they were not enrolled, the medical assistant would then offer to place the child's name on a state online referral form, and then they would receive outreach from WIC. If the parent or caregiver did not want the online referral, they would receive an informational handout about WIC. The data on this slide is less important than I feel like the slides of the graph. It's basically an illustration of the first efforts and the minimal success that we had with this. Although we had good questioning and the medical assistants asking most of the patients seen, we did not have high rates of uptake for placement, for the name being placed on the online referral, and then little uptake for enrollment. So this early intervention, showing that referrals and handouts really didn't lead to an increase in enrollment, brought us to where we are now. As Kate had said earlier, we've routinely been screening for food insecurity, and that has been spread to the ambulatory care clinic, all of the ambulatory care clinics now. And we continue to see high rates of food insecurity and continue to ask the routine question about screening or about participation in WIC during the MA rooming. And now we've moved on to some next steps in terms of our process to improve enrollment.
Okay, so our next steps included a process to start to improve the protocols that we're using to make those referrals and to have families connected with the much needed community food programs. And so we followed a lean process, and lean is a systematic approach of continuous improvement, and it's based on the Toyota production system. And the goal is to identify and eliminate waste. And we use the lean procedures to put the customer first and systematically problem solve to make our processes more effective. And one of the techniques used is called the Plan, Do, Study, Act cycle. And so we were able to start some initiatives, study them, and then modify them as needed. And some of the key players that we used were Medicaid enrollment specialists, SNAP specialists, and WIC, so that we could try to incorporate these much needed benefits into the medical visits and reduce the resource burden on our clients. And this also involved brainstorming how we want to collect data and show that this change in process was successful. And so this first started with mapping out the disconnect. We wanted to learn why the connection was low between making the referral and obtaining the benefits. And so our first session and kind of our final wrap-up of planning was to work with the frontline workers to determine how this process would work. And initially, this is what we found. We found that the 4 systems worked independently of each other and that they were siloed. And even though referrals were made and some of the programs were co-located, so they shared the same building or they shared the same campus, we still weren't seeing referral ending in enrollment in these programs. And this can be really frustrating from the client or the participant or the patient side, because lots of times the same questions are being asked and the same documents are being requested. And this current protocol ends up in multiple appointments for the family. And so what we wanted to see was an integrated approach that was behaviorally informed to help improve the customer experience across these assistance programs. And we wanted to enroll more families while they were with us on our campus or in our building for those important medical appointments. And we decided to start with the WIC program because WIC was co-located within 6 of the Denver Health ambulatory care clinics. And so that was our first approach to really integrating services. And so what does integration look like versus co-location? The co-enrollment, we wanted to shift to be more of a patient-centered model to emphasize convenience and also stronger relationships between departments. And we did this by leveraging existing touch points of Medicaid beneficiaries, eliminating barriers to multi-benefit enrollment, and developing messages to address fears and concerns of community members. We also trained behaviorally informed co-located credentialed staff who could enroll families in WIC and form relationships with the medical teams to complete 2 appointments in the time of 1. And we wanted to scale up existing pilots to ensure sufficient navigation staff and informatics support and share knowledge out about the enrollment. Another part of integration is really advocating for adequate funding for these programs so that they can continue, and addressing family concerns possibly related to low trust of the government and any symptoms of anxiety, depression, or mental health stressors that could prevent a family from enrolling.
Thanks, Meg and Kate, for giving us that background and that context. So now you might be wondering, so what is co-enrollment? Why use the word co-enrollment? And we decided as a group that we wanted a common terminology, but something that would be broad, so that way we can start small, like Kate has mentioned, that we're going to start with integrating WIC services into the medical care setting, not just co-locating, but we want to hopefully expand that based off of what our success looks like. We really wanted to emphasize convenience and synchronization, and our goal was really to collaborate with different programs, understanding that they are administered by different agencies and they come with their own protocols and their own priorities. How do we align this service delivery and expand access? So, and all whilst improving relationships, both between staff and with the patients of Denver Health and participants of the co-enrollment program.
All right, so for our co-enrollment model, we had some key players that have allowed this project to be successful. So we applied for a grant to help fund this work, and we had a project principal investigator. It also involved pulling in some of the WIC supervisors to support the WIC enrollment specialists. And key player was a medical champion within the healthcare centers that we were integrating service. And the medical champion really helped to build the relationships between the WIC program and other departments. The co-enrollment coordinator, who is Brittany, helped to organize the grant deliverables and make sure that we are meeting those goals. And within the WIC program, we trained co-enrollment specialists to enroll in WIC, improve relationships between departments, and have some behavioral training in their back pocket for when they need it. And then we have dietitians on staff for higher nutrition needs to provide extra counseling. And then, of course, our medical staff, the medical assistants, the nursing staff, and the physicians who helped us to integrate this service. And then we monitor this through evaluation. We provide ongoing training and coaching to ensure that we are meeting the needs of the families. And then we reach out through community engagement so that we can continue this great work. And so what does this look like within the clinic? We have our WIC co-enrollment specialists, and the first step is determining if a WIC appointment is needed. And so this was done through collaborating with our provider teams and also with the electronic medical record to run some reports so that we can identify which patients who are coming in for their primary care visits also require a WIC appointment. And once that was identified, then the patient was offered the opportunity to be enrolled in WIC or to complete a WIC appointment at the same time as the provider appointment. And initially we saw this as the patient completing both appointments at the same time within the exam room for that appointment. We did, however, find that sometimes it could be related to what time the patient arrived, the needs of the clinic, the flow of the clinic. Sometimes that was not the model that was used. And so we had to adapt and make some changes. So the initial idea of rooming in is a great model, and we continue to use that as we are able. But we also found that it was important to maintain flexibility and allow those WIC co-enrollment specialists to complete their portion of the appointment before or after the provider visit. And then having a warm handoff was important as well. So if the family has already completed the provider appointment or the needs of the clinic don't allow for the WIC enrollment specialist to room in, then we would be able to refer the family right away to a person who can help them complete that appointment while they are still within the medical office. And then our final option was to complete the visit over the phone, again, trying to save some of those valuable resources for our families. And as I mentioned, we utilize the electronic health record or electronic medical record. For our Denver Health Hospital system, we utilize Epic. And this
medical emergency, pediatric in the lab, medical emergency, pediatric in the lab, medical emergency, pediatric in the lab.
I apologize for that. So this allowed us to view Epic Notes just for the purposes that WIC has for enrollment. And so that was utilizing Epic to gather weights and heights and hemoglobin values. And this helped to save the family time because in the original model, those anthropometric data and the hemoglobin values would be collected by both the provider and the WIC office. And so this allows the family to have less appointments for that. We are also able to verify contact information and occasionally Medicaid numbers, which is documentation that is needed in order to enroll families in the WIC program. And that reduced the amount of documents that the family had to come in and the appointments. And then the dietitians can message providers and make sure that we're having coordinated care with our families for some of those higher nutrition related risks. And another benefit of the WIC co-enrollment specialist utilizing the Epic system is that they could view the reports and the schedules to determine which families could benefit, and also write notes in the schedule and communicate directly with providers to ensure that we are reaching all of the families who are eligible for these services.
Thanks, Kate. And we're about to get into the data heavy side of our presentation. And so now feels like the right time to share that at Denver Health, we have just begun our journey really towards being intentional about how we present and talk about data, because it's all in relation to people, and people are so much more than just numbers. There's a whole story behind these numbers. So we want to be intentional about that. And, myself, I want to connect with you and with our staff and talking about our project and recognize that there are blind spots everywhere. I have blind spots. And as we continue to talk and work through this program, we want to address those as best as we can, recognizing that we are also human. So just want to share that first. And Kate, you can go to the next slide. So how did we understand or know about whether or not we were successful in this project of specialized co-enrollment? What was our true north? How would we know if we've hit the mark or missed the mark? So we really used as our lens and our framework to look at the value diamond. Now, I don't know if you guys can give a show of hands, and you could do the raised hand feature. Is anybody familiar with the value diamond? Okay. Yeah, it's not always used in healthcare settings. Going back to our lean work, this is really about trying to understand putting in this case, it would be our participant or our patient in the middle, and then trying to systematically problem solve to make processes more efficient and effective. And you'll see those 4 points of the diamond is satisfaction, time, quality, and finance. So those were all considerations that we wanted to think about when thinking how and if our program would be successful. We also, during our teamwork in preparation for this came up with a must-have and a good-to-have list. And as you see here on our must-have list, I want to just point out a simplified process for our participants. Also, value seen by everyone. So this is the participant. We want them to feel and understand the value of this program, but also our medical staff and our WIC team, who are our ultimate, we want their buy-in, because ultimately they're our gatekeepers. They're the ones promoting this program, and they are going to be ensuring our sustainability of this. So it was really important that they also see the value of what we're doing. In terms of what's good to have, we wanted net equal or less time for participants. We understand that time is a very valuable resource. And so we wanted to try to keep things as tight and concise as possible, and also transparency for that participant, and keep them informed of this navigation and support that we would be providing them. Next slide. So here's just a few numbers of how many people we served. In 2021, we started rolling out this model out of 2 outpatient clinics, and we focused on 2 outpatient clinics that served either some of the highest volume of our pediatric appointments or our OB appointments. So those are pregnant individuals, knowing that those would be who would be most eligible for the WIC program. In our first year, we served 759 individuals out of those 2 clinic locations. And starting in 2022, we actually expanded to 4 clinic settings, and we're able to serve over 2,200 about 2,240 individuals through this model of integrating WIC into the medical appointments. And services included, but we're not limited to enrollment, but also the required appointments to maintain WIC benefits. So something that I believe Kate mentioned is a primary difference between the administrative process for WIC and SNAP is that WIC requires 4 or so check-in meetings with families and a WIC representative to maintain the benefits of that program. So it's important not just to get on the program, but to maintain benefits. There's also other services that WIC is able to provide and that we were able to provide to these 2,240 individuals, including lactation counseling, nutrition education. This all came into focus, particularly in this formula shortage that we've experienced over the last year. There are a lot of new families who weren't sure what to do or how to navigate this. And so integrating WIC and having somebody represent the WIC program was really useful for our families to provide the counseling and also some of the equipment to provide lactation services like pumps and things of that nature. Next slide. An unintended consequence of our program, which we're really excited to share out, is that we were really good at retaining WIC participants in the WIC program through our intervention. So as you can see here, just under 39% of our participants in specialized co-enrollment were new to WIC, but that means over 60% of our participants were retained into the WIC program. So those individuals were receiving some of these appointment types are called mid-certifications that happen 6 months after being enrolled in the program or certified in the program. There are follow-up required appointments, and so we were able to complete those during the medical appointment. Another thing to note is that due to the public health emergency, we were able to provide services in unique ways that served our patients, like virtual appointments or serving entire families, even if not all family members were present at that, for example, pediatric appointment. So we really took advantage of the opportunities that COVID allowed for us to have. And then also something to note is that WIC funding is really related to WIC caseload. And so the larger the caseload, the more funding and thus more staff to serve more individuals. And so it can also work the other way, which is when there are times when the WIC program is short-staffed, and if caseload decreases, then there is the threat or the risk of lower and smaller budgets. So we're really happy to see that over the period of time when we've been serving Denver Health patients with this co-enrollment model to promote WIC, the WIC caseload at Denver County has increased, and you can see it's increased by a little over 1,000 since September of 2020 until September of 2022. So we're really excited to see that. Next slide. So who did we serve? You know, we told you the number. We told you we served 2,240. But who are these individuals? We were able to pull demographic information through our EPIC, our electronic medical record of the patient being served. So on the left-hand side, you'll see a donut chart. And so you'll see about 50% of our newborn patients were served through, excuse me, let me rephrase, of our intervention of the folks that we were trying to leverage a touch point, 52% of those were through newborn appointments. And then you'll see just shy of a quarter were kids ages 1 through 5. So we were able to provide an intervention of doing WIC enrollment during those child visits for those ages 1 to 5. And then you'll see about a quarter were adults. And so those are really for the OB appointments that we're discussing. Those are for expectant parents. They're coming in, they're getting checkups throughout their progress. And so we were able to provide that intervention to those individuals. About 69% of our patients that we served through this intervention spoke the language of their heart being English, and about 68% were Hispanic or Latinx. And these are just the top 3 languages and the top 3 ethnicities and races. There were others, but they were in smaller percentages. Next slide. So those are some of the numbers, but then, you know, as I had mentioned in our value diamond, we really wanted to understand what is the perspective of our participants? What did they feel that there was value in what we provided to them? So we conducted a survey. It was a 11 question survey. We received 204 survey responses, and we did incentivize folks through a gift card to provide their feedback. And we offered this in both English and in Spanish, both via a paper survey and electronically. They could fill this out on their smartphone. So all of these responses and the data that I'll show you from here moving forward was provided in both English and in Spanish, and then I synthesized information to be all in English. So 100% of our survey respondents said that either our program was very useful or useful, with 98% of those folks saying our program was very useful. 96% said that there was nothing about our program that they disliked, and 98% said that they would recommend this model to others, which is fantastic to hear. And then lastly, 100% of our survey respondents said that they found that the doctor office connection to the food and nutrition resources was very helpful. And I just want to preface that this was all offered on a Likert scale. So there were 4 to 5 options for folks to fill out, from very useful to useful, neutral, disliked, really disliked. So we're thrilled that overall it's been more than just a little positive. It's been overwhelmingly positive. Next slide. One of our 11 questions asked participants to put in their own words what their experience was. And I pulled out a few of the responses and put together a digital word cloud. Every one of the free form responses were positive. And as you can see right in the middle of the word cloud, helpful was used the most frequently in all of our feedback. There were over 50 times when the word helpful was used. Convenient was used about a dozen times in our feedback. I also wanted to include one of our Spanish comments at the bottom. And in case you do not speak Spanish, translated, it says, "I like that the nurse and the WIC person worked together to get the appointment done faster." Next slide. Another one of our survey questions asked participants, what was the best part of, and what we called it a shared visit, but that's really our co-enrollment. That's our integrated model of receiving WIC and medical services in one. And as you can see, the number one response was, and 74% of folks indicated receiving WIC and medical services during the same visit to the clinic. I also want to note that 47% of our respondents said that knowing my doctor and my WIC team were working together to support me and my family's health. That was also amongst the top three responses. So our participants also recognized and appreciated the collaboration that was happening between the different teams and different departments. Next slide. We asked our participants, did our program, our model, save you and your family any resources? And you'll see on this bar chart that 77% of respondents indicated that our program saved them time because they were able to receive 2 services in the time of 1 visit. Also, the next 48% indicated money was a resource saved, followed by 41 indicating transportation, savings in transportation, and 26 indicating a savings in childcare. Now, we know from the literature that these are historical barriers to receiving WIC benefits, and so we were able to break down those barriers through our model. Next slide. We also, going back to our value diamond, we wanted the value to be seen by everyone, not just our participants. And as you hopefully gleaned from our previous slides, they overwhelmingly enjoyed and appreciated our program. But now we have to shift to the staff perspective. What did our staff think about having to change up their workflow? Bringing them, I think, a little outside their comfort zone of what their general duties would be, participating and helping to co-design work. This might have been a lot of professional development for some individuals. So we conducted key informant interviews and a survey to understand from the staff perspective what their experience was. So as you can see on this slide, there were really 2 key benefits that across the board our staff communicated about. One is improved efficiency, and 2 is interprofessional collaboration. Next slide. As you can see from some of these quotes, this really speaks to those 2 themes. So before our co-enrollment model, clinical teams and WIC teams didn't necessarily have a strong relationship. Often they would be sending emails or faxes to one another, even if they were in the same building, but not necessarily know who the other person was on the other end. Since our model, I feel like what we've seen and what we've heard from our staff is that these two departments, these two teams now know each other by name, by face, and they'll often walk over to one another's clinic area to discuss treatment planning and referrals. The clinic team is also much more familiar with the WIC offerings and more frequently will be giving referrals to WIC. As Meg mentioned in the beginning, an MA, a medical assistant, might say to a family, are you interested in the WIC program? But might not be able to really speak to what the program is and what the benefits are. And through our collaboration and working on the co-enrollment model, what we've heard and what we've seen is that the medical team feels much more comfortable and confident broaching the topic with patients and actually speaking to what the program does, and vice versa. One of our staff said, I think that the clients like dealing with the same WIC person from the phone call to the meeting and sometimes even follow-up care. I think that it helps build trust. Like, yeah, I know this person and they know me and my family. That building of relationship and consistency with the participant or the patient is also really positive. Next slide. So we've learned a lot over the last year and a half, almost 2 years of doing co-enrollment, and some of them are listed here. So as Meg mentioned, even with co-location, there are barriers, but integration has a lot of potential. It might take more work, administrative work on the front end to make that possible, but on the patient or participant facing end, it ends up moving very smoothly, and a lot of all around, I would say 360, we see there's an improvement in our process. So what other lessons have been learned? Collaboration is rewarding and it does create a stimulating environment for all. Our program is not perfect. There are definitely recommendations that our staff give us and we try to make those all very actionable, but it is nice to see our staff kind of grow into this place where they can provide feedback and provide suggestions about what they're doing day to day and how to improve that. Also, systems change is hard. With all of us on this call or in this session, I think we can all agree that it just is common sense to better integrate these services that are complementary to one another. But the way that our current system is built, it does not allow for that to happen very often. So systems change is really hard and it's slow going. We've tried our best to make inroads and then through programs like this, really advocate for further integration of our different programs. Also, our participants love this model and they love that we're taking the guesswork out of navigation of services, which also is a barrier to often receiving these services. Anything else that I've missed in terms of lessons learned, Megan and Kate, that you want to speak to? Or
I think that the lesson that we have learned working directly with the clinics is really just that this type of model can improve relationships, not just with the clients, but with the other medical teams. And also that this model has allowed for the interdisciplinary teams to really put the patient at the center of care. It does take some flexibility, some adaptability from both ends, but the benefits have really come through in the surveys for both the patients and the staff.
Thanks so much. All right, so what is the future of co-enrollment? We know that this model is successful and that our patients really love it. So we would also love to expand our menu of services using this model. We asked the question in our survey, what additional resources are of interest to you? And as you can see, almost 50% said food. So I'm assuming that if there's the SNAP program, but there are other food related resources that we can be driving to our patients. We have been actively working to figure out how we can best integrate SNAP I don't know about the states that you guys are representing from or what their regulations look like, but in the state of Colorado, the SNAP program and the WIC program are administered by different agencies, and thus data sharing can be challenging to recognize who of our patients at Denver Health are also eligible for, and wondering, you know, are they enrolled in the SNAP program? We don't want to duplicate efforts and bombard folks, but we do want to make a concerted effort to approach and contact patients who would be eligible for these programs. We also recognize that this is a symptom of bigger systems change work. So if people are identifying that they are food insecure, but they're also housing insecure or transportation insecure, these are larger issues that we want to continue to advocate for. But in the meantime, how do we make Denver Health a place where access to these different services is more available? Next slide. And so I'd be remiss if I didn't thank our partners. As Kate mentioned, we have been grant funded to really put dedicated time and staff into building out this model for sustainability. And so we've been working with our local public health agency, Denver Department of Public Health and Environment, who administer a grant called the Healthy Food for Denver Kids program. And we also received funding from the Albertsons Foundation Nourishing Neighbors, and they have been really wonderful to work with as well. And the Public Health Institute at Denver Health is also listed here. It's a department within Denver Health. It's actually where my position is housed, but they provide a lot of our community engagement and evaluation support. And so I just really want to call out and thank them. And with that, we really want to thank you all for listening to our presentation and learning more about the work that we're doing and how we can uplift each other's work, and leave time for questions. I don't see any Q&A questions. So if folks here just want to call it out and don't mind being off mute, I think that would be a great way to engage in conversation. Unless we've answered all your questions.
Christine, did you have a question? Looks like Christine is able to unmute, but we're not able to hear her. Christine, if you do have a question and we're not able to hear you, go ahead and put it in the Q&A. Well, big thank you to both of all three of our speakers today. We're so glad that you're here. Thank you for such an informative session. I'm killing a little time in hopes that Christine could get her question into the Q&A and that there's still time for us to be able to address that. We appreciate you all bringing your learnings and all of your hard work. As Christine maybe takes a moment to see if she's able to get that in. If not, I want to just let everyone know about what's coming up next. So up next, we have a 30-minute break and opportunity to check out our on-demand content in the lobby. We'll then begin the next set of 4 workshop sessions that will address establishing healthy connections and child and retailer food health. To join one of those 4 sessions, you'll click Workshops in your navigation bar to the left of your screen, and you can view all 4 workshops being offered by clicking the blue arrow to the right, then click Enter Session. A reminder that one of our upcoming workshops called Expanding Healthy Food Options at Retailers will be presented in Spanish. English interpretation will be available for this session. If we don't have any other questions coming in, you all are welcome to hang out here for another minute if you have any questions for our speakers.
Sam, Christine did put her question in the chat,
good.
so I'll just read it aloud, and I think maybe Kate, you can answer this, or Meg. Did more buy into WIC from the medical providers because of their feelings towards the WIC program?
I think that the medical providers really started the relationship with the family, and then being able to show that there is interdisciplinary relationships and that WIC and the providers work together really helped to increase buy-in for both services. I think that having a provider make a referral that maybe doesn't go anywhere or is just a phone number can sometimes reduce some of the trust. And so having that relationship helped to build trust in the WIC program and the provider. I hope that answers the question. Kind of a two-way street.
And Meg, did you have any comments? Yeah, please.
Yeah, I can also add that, as a medical provider, we hear myths about programs, not just WIC, but about a number of different federal programs, and it allows us to show to dispel some of those myths, to help with, like Kate had said, when we make a referral and it goes nowhere, that can be frustrating for providers and for families. And so when we have that opportunity to have more integrated contact and direct warm handoffs, it makes it more successful. So I do think that when there's an opportunity to leverage our relationships with the families, our frequency that we see families, and the ability to bring the disciplines together can make a difference.
And I'll just finish us off by saying we've really tried to normalize this. So if the medical team can say, and yes, they might be a trusted member of the community, but they might not be as well. There's a lot of history there between our communities of color and the medical teams. And so, but if there's this opportunity to say, as part of our process during the well child visit, we could have somebody from WIC come in. It looks like you might be eligible for the program, to really normalize that and destigmatize. Looks like you might be income eligible for WIC. It's more like, hey, you're here for a well child visit, and there's a service that you'd be eligible for and would be complimentary to this service. So, and I will say it goes both ways. I think that the WIC team, they try to do outreach as well, preemptively to the medical appointments when it makes sense. And they also are able to jumpstart that relationship and say, hi, my name is Brittany. I represent the Denver WIC program. I would love to see you tomorrow when you come in for your pediatric appointment or for your child's pediatric appointment. So I do think it goes both ways. Hope that answers your question, Christine.
Thank you so much, Christine. I'm sorry we weren't able to hear you, but I appreciate you adding your question to the chat. Thank you, Brittany. Thank you, Kate. Thank you, Meg. We so appreciate the three of you being here. This will conclude our workshop. So to exit the session, please click on the red phone icon at the bottom of your screen, and then you can click leave. Have a great rest of your day, everyone. Thank you.
Thank you.
Thanks, Sam.
Thank you. Great work, team.
Yeah, good job.
Yes. Thank you so much for your technical assistance.
Yes, very much.
Awesome. Okay, I'll see you guys later. Congrats.
Thank you. Bye.